I'd like to thank Conceptual Orthopedics for letting me speak on this important topic on the PCL. Now, when I was a postgraduate student, all I knew about the PCL was that PCL is an important ligament within the joint, and much of the intricacies of the PCL were not clearly understood by me at that particular stage in my life. But now I realize that clinical practice is changing. When I was a resident, sports medicine used to be only a small portion of an orthopedic PG's curriculum. Now, I think an orthopedic postgraduate student can expect to see up to 50% of his surgical cases as sports medicine cases. So therefore, it is important to know a little bit of PCL in reasonable detail. These are the 5 headings under which I will discuss this particular ligament. Let's start with the anatomy. Now, the most important fact, if there is one thing which you want to remember about PCL anatomy, it is this. You must remember that PCL starts below the level of the knee joint line. And this seems something very simple, but it is quite surprising as to how most people are not aware that PCL has to start below the knee joint line. The distance below the joint line can vary from 15 to 25 millimeters, but it is important to know that this ligament starts right in the center on the tibia below the joint. Now, any ligament's anatomy has to be studied with respect to its footprints. I would recommend all students to go through the fantastic articles by Dr. Robert Laprade, whose work all these diagrams are taken, and who has a huge volume of work on all knee ligaments, especially the PCL. On the left, you see a cadaveric specimen, and on the right, you see a sketching of the PCL anatomy on the femur. And it is immediately obvious that the PCL has 2 ligaments, a vertically oriented ALB or the anterolateral bundle, and a relatively obliquely oriented PMB or the posteromedial bundle. The AMFL is the anterior band of the meniscofemoral ligament, which is sometimes seen attached to the posterior horn of the lateral meniscus. It passes in front of the PCL. Similarly, the posterior band of the meniscofemoral ligament that passes behind the PCL. Now, when it comes to this sketch, you must notice these 3 points. If you look at the mouse cursor, this particular point where the intercondylar notch takes a sharp turn to the medial side, that is known as the trochlear point. The second point where the same notch takes a vertical dip, that is known as the medial arch point. And then there is a posterior point as well. The posterior point is at the lowermost part of the femoral condyle, from which the condyle takes a back turn. So these are the 3 points of surgical relevance, and it is easy to see from this figure that the anterolateral bundle is between the trochlear and the medial arch points, and the posteromedial bundle is between the medial arch point and the posterior condylar point, as can be clearly seen. And again, it is important to note the presence of this depression. It's a normal depression in the articular cartilage of the lateral femoral condyle, known as the sulcus terminalis. Now, when it comes to the surgical anatomy, we view any knee ligament with the knee at 90 degrees of flexion. And this is how the footprint of the PCL on the femur would look to you when you look at it with the arthroscope. Again, the thing to note, this may be a bit overwhelming for a postgraduate student, but what you must try to remember is the presence of a small ridge in between the anterolateral and the posteromedial bundles, known as the bifurcate prominence or the bifurcate ridge, and the presence of the anterolateral bundle between the trochlear and the medial arch point, and the posteromedial bundle between the medial arch point and the posterior point. Now, these distances are not important. It is, of course, good if you know these distances. They are very useful from the point of view of surgical reconstruction of the PCL. But what is more important to know is that there is a wide spread between the femoral origins of the 2 bundles, that is the anterolateral bundle and the posteromedial bundle. They are very wide, and that is one of the rationale why a double bundle PCL reconstruction is often advocated. And the average distance between the centers of these 2 bundles ranges from 12 to 18 millimeters. Coming to the tibial side, so on the left, you see a sketch. On the right, you see a cadaveric specimen. Again, work taken from Dr. Robert Laprade's seminal article on the anatomy of the PCL. Important things to note are this particular point, the shiny white fiber point. The shiny white fibers are a part of the posterior root of the medial meniscus, and they are very easily seen during arthroscopy. So these reference the tibial footprint of the PCL. And here again, you can see a distinct anterolateral and a posteromedial bundle. But unlike the femur, you note that these are very tightly clustered to each other. This is another important landmark to note. This is called the champagne glass drop-off. Now visualize a champagne glass, just like it has a sharp drop-off. The tibia almost falls off beyond this point. So in the sketch, it is important to note that with respect to the posterior joint line, the tibial attachment is below it. Now, this is a very, very important fact to remember. It seems simple, but trust me, it isn't. The other important thing to remember is that the bulk of the PCL ligament is oriented relatively vertically, almost 12 o'clock. So between 11 and 12, but it is almost vertical. Now, this particular position confers the maximum biomechanical advantage to the PCL in resisting posterior tibial translation. So that's a close-up of how the various relationships are. And again, you see the PMFL, or the posterior band of the meniscofemoral ligament, which goes from the posterior horn of the lateral meniscus and attaches just posterior to the posteromedial bundle of the PCL. This is how you see things arthroscopically. And again, the shiny white fiber point is very easily visible and can be used as a good landmark to reference the tibial footprint of the PCL. Here again, remembering these measurements is not important, even though it is not a bad idea to remember it. What is more important is to note that at the tibia, the anterolateral and the posteromedial bundles are very close to each other. It's a very compact ligament at the tibia. The average distance varies from 8 to 10 millimeters. Therefore, one can get away by drilling a single tibial tunnel and two femoral tunnels in the femur. That is the rationale behind a double bundle PCL reconstruction. And this is how things look arthroscopically. And you can almost always see the shiny white fiber point. That is a small bundle of shiny white fibers, which are just associated with the posterior horn of the medial meniscus. These are the pertinent anatomical relationships, and what is important to note in these diagrams is the proximity of the PCL tibial attachment to the shiny white fibers. So if your PCL guide wire is in the center and you are drilling a 10 millimeter tunnel, almost the edge of the reamer will come right at the cusp of the boundary between the footprint and the shiny white fibers. Now imagine if your guide wire is not appropriately placed, and if it is placed somewhere here. So while drilling the tunnel, you can actually detach the posterior horn of the medial meniscus. So this important relationship must be kept in mind. The posterior horn of the medial meniscus is within millimeters, to be exact, 6 to 8 millimeters anterior to the PCL tibial attachment. So this is an important relationship to be kept in mind while surgically reconstructing the PCL. So that's a broad overview of the anatomy. And when it comes to biomechanics, it is useful to know that the PCL is the strongest ligament of the knee, and its primary function is to restrain posterior tibial translation. It also secondarily serves to restrain external tibial rotation, and these two biomechanical facts are utilized to our advantage when we want to clinically examine a patient for PCL insufficiency. Another thing to remember is the phenomenon of codominance. Now, generally, when you describe a ligament as having two bundles, it is common sense to think that one bundle does something, the other bundle does something else. But in the case of PCL, it has been found that in most activities of day-to-day life, both the bundles, they work synergistically. Now, this was proved in sectioning studies, this was proved in load studies.